Thanks, James. Now, I think unlike Stephen last year, I'm actually tethered somewhat to this spot, so I don't know whether they were worried about me walking off the stage or what, but I will introduce the panel, and for those of you who've been to these sessions in previous years, we'll have a range of questions that I will ask them to open up the discussion, and then we'll also take questions via the app and via the open mic at the end. And we have asked for the heating to be turned up. It is pretty frosty here. I'm okay. I think the panel are feeling the cold, so we'll see if we can get it a bit warmer in here. This is a slightly smaller panel this year. We are missing the Northern Territory and Tasmania. I think the Northern Territory has a rural health conference on, so I'm not sure if that's where their interests are at the moment. But I'm sure you know all of these people, but let me do brief bios for them. Frances Diver, Deputy Secretary in Victoria, Health Service Performance and Programs. So Frances is responsible for managing governance and formal accountability arrangements, including the performance of public health services across Victoria, policy and program development for acute health and ambulance services, the delivery of a $2.3 billion capital program, health data collections and quality and safety programs. Next to Frances, and actually I should just make a mention because we did comment, this is the most gender balanced panel we have ever had at an ABF conference, so thank you. Usually it's, yeah, so great. So then we have Neville, Onley from New South Wales. Okay, we've the panels actually distributed themselves not in the order of these bio notes. So Neville is currently the Director of ABF Taskforce, established in September 2011 to oversee implementation of ABF across the state under the now disappeared National Health Reform Agreement. Prior to leading the task force, Neville had a number of senior positions in the health system, including Director of Financial Services for the Southern Clinical Support Cluster and as Director of Finance and Corporate Services for former South Eastern Sydney and Illawarra Area Health. We then have Janet Anderson, First Assistant Secretary in the Commonwealth Department of Health. She held senior roles before joining the Commonwealth in the New South Wales Ministry of Health and has worked across the Australian public health system over the last 25 years with a range of positions at Commonwealth, state and regional roles. She was awarded the Public Service Medal in 2000 for outstanding public service in health policy development and reform. Next we have Winston Piddington from ACT Health. Winston has actually travelled the country in the pursuit of better ABF systems. He started work in Tasmania and I didn't write this but I thought it was a great line, led by one of the Australian ABF National ABF Treasures, Kevin Ratcliffe, who presumably is not here today. I'm not sure if a national treasure means you're wise or old or both, but so Winston, you've got something to look up to there. Then Winston went on to work as an ABF consultant in Ireland. He's also worked in costing in New South Wales and then to IPA and now in ACT Health, where he co-manages the program with Mohan Singh, who many of you would also know. Beress. All right. Oh, Beress, where's Beress gone? There you are. Beress, Director, Health Service Purchasing, Department of Health, Western Australia. So Beress obviously has responsibility, as all of the people on this panel do, for health purchasing, including ABF funding and management methodology. Prior to this, he held a number of senior roles in the WA public health system and in the metropolitan area health services. Okay, Nick, Queensland Health Executive Director. I said to Nick he has the distinction of having the longest title here on the screen. I'm not going to read it out. So what this means is the development of the Queensland Healthcare Purchasing Framework, implementation of national ABF model, and contractual agreements and arrangements with hospital and health services and the Mater. And finally, Jenny Richter, Deputy CE from South Australia Health. Jenny's had a range of roles in the public health system, the private system, returning to South Australia in 2011, where she's currently the Deputy CE of System Performance. Again, 25 plus years in the health sector as a nurse administrator and executive in community nursing. As I've said, also the private hospital sector. So, to kick this off, as we know, the focus of this year's conference is about transparency and efficiency, and we've actually had quite a lot, I think, this morning already in the sessions, both from Keith Willett and from Di Watson on transparency. So I thought we'd continue that theme a little bit and talk about counting and classification systems. Because clearly you can't have a transparent system unless you've got some good classification systems. So I'd like to ask the panel to reflect on a two-part question around classifications. And so the first part is what they think the major achievements have been in classifications in the last few years. And I encourage you not to shine your light under a bushel. If there's something that you think you're doing really well in the classification space, that is in addition to what might be being done nationally, please speak up. And then, apart from the good, where is there still a lot of work to be done? And so what are the priority areas? So if you could pick one area, where would you like to invest some time and effort in classification development? And we'll do this randomly with whoever looks eager. Okay, that might have put them off. Sorry. Jenny, you're making eye contact. That's a good sign. That's what happens when you get more women on the panel. They sort of naturally engage more. Not really. Not really. Come on.
No speaking for the blokes.
Thank you, Sharon. So, South Australia has been a case mix state for many years. So from a classification point of view, the achievements to date in the last few years have probably not been as pronounced as other states who haven't been into case mix until recently. We think that it'll actually be in the next few years that we'll see the major impact for us. Particularly, we're looking for the conclusion of the classification work that's being done around mental health. We think that will help us significantly in that area. And we're also looking for outpatients and emergency department classifications to be developed up, understanding that that's a proposed piece of work. You know, with emergency, for example, the limitations of the triage process, we think that a better classification system would improve the way in which we understand what's happening in the emergency departments and better reflect patient severity. Teaching, training and research is the other piece of work that we're really looking to have that brought to a conclusion. Whilst it's not big dollars in the scheme of things, it's really important for us to understand how, in fact, those dollars should be distributed across our system. So I think that's all from South Australia for a minute, Sharon.
So fairly similar to what James was essentially taking us through this morning?
Quite possibly.
Yes, okay. we didn't actually rehearse this or coach this, so does anybody else have a different view around either... and when we talk about achievements, I guess I'm looking to find out the extent to which any of these has had any real use or implications for your jurisdiction to date, yep, and where the gaps are.
Sure.
Winston?
Yeah, talking about our major achievement over the last 5 years in classification and costing, there was a stat that I came across the other day when we were looking at our hospitals. Talking about achieving further transparency, we now classify, count, and of course on my side, cost the bulk of our hospital services. We looked at a stat the other day that was saying that we actually classify and count 93.2% of our hospital services across the ACT. Now, I don't know if any of you across here have worked in this field long enough, but I remember being back in 2004-5 and coming up with a product fraction, just a made-up figure, to actually give an idea of actually some of those services in which we count. Now, some of that was maybe 60 to 70% we were covering, but it's just a figure that shocked me the other day, that when we worked out that we actually count and classify 93.2% of our services. So if anything, congratulations to IPA, that we're now able to have a better view of what our hospitals actually deliver to the ACT.
Francis?
I'm happy to make a comment, probably slightly contrary. James won't be surprised. From Victoria's point of view, one of the things that we are most encouraged by and think is most interesting is the increased classification and coding work outside of the acute space. So subacute, outpatients, ED, all of that. That's all good, and teaching, training, research, the attempts at it are interesting, and they're the things that we're most interested in. However, I would say that we're not there yet. We're a long way off. And in fact, the thing that I think is kind of most interesting is that as we do that work, we actually recognise that maybe a case mix model is not necessarily applicable, or an activity model is not necessarily applicable in those cases. So we need to find interesting ways of funding those services, and we need to start classifying and coding them. We're a long way off using those models real time in jurisdictions, I think. So I think it's interesting work, it's really important work, but I don't think we've reached a conclusion. And from Victoria's point of view, I think what that's done is accelerate our thinking of alternate models for some of those areas. And so in terms of real live outcomes in Victoria, I think what we've done is accelerate our thinking that actually some of these kind of case mix models are not necessarily going to be applicable in those areas. And we've also done and then a separate point, I guess, we've done quite a bit of work recently on kind of getting the capitated model for the high-risk patients, whichever version you want to kind of talk about, but identifying around 18,000 people who are acute inpatients that we think we can determine a different way of funding that we think will free up resources at health services to develop alternate models of care. So kind of 2 points really. One is lots of good classification exploration in the non-acute world. We should keep doing it and work out what we need to do, but I'm not sure we've reached a conclusion how we will fund. And then on the acute inpatient side, actually going away from ABF in some ways for some groups of patients to come up with a different financing model to allow services to do the right thing by patients.
Okay, so that distinction, transparency, was useful to actually understand the business activity that was being undertaken, but it didn't necessarily flow into a funding model, was your observation?
Yeah, I think so. I mean, I think we're not there yet on some of those classifications, and it'll take a while. So I'm more confident in subacute. I think we might get somewhere with the current classification and coding system to get a funding model. Teaching, training, research, I don't think we're anywhere. Mental health, I don't think we're anywhere yet. And that's really forcing us in Victoria to think about, well, what else could we do? And so we're probably, that's really prompted us to do a little bit more work to accelerate different models locally.
Neville, do you?
Yeah, look, I'm in line with a couple of the comments. I think the fact that we've, certainly in New South Wales, we've come a long way in terms of transparency and knowledge and so forth. We couldn't have done that without classifications, good, bad or indifferent. We couldn't have done it without it. And the fact that we've gone from just essentially the acute and ED classifications to now cover the 97% and so forth of hospital services or wherever it might lie is a good start. Yeah, we all agree that we haven't got the perfect classification systems yet. There's still a lot of work to be done. I agree on the mental health, the non-admitted space, still got a lot of work to be done there. And I'll expand it further and say the small hospitals models that have come into play as well, because for us there's a significant amount of work happens outside the ABF, yet it comes into the pricing and scoping mechanism. The mere fact that it does that brings it into the ambit of being able to have information and sufficient insight into it to start making decisions around it and where it should go and how it should be treated. If, as we mature through the classification and the funding processes and the management processes where we've moved to, if we come across elements of the system then that do require specific adjustments to the funding, well, that's good. That's good for the system, and that means that what we're trying to do in this whole space is working.
Okay, so I've heard a couple of people, and I will get to the other panel members, but I've heard a couple of people essentially say that they have, if you like, leveraged off some of the national classification work to say it's taught us something, but it isn't necessarily fit for our purposes, so we've done some other internal work internally. I haven't heard a lot about internal classification development work.
We've been dabbling in the area and looking at where we can try and do a bit more work. So in trying to prepare New South Wales for the non-admitted mental health area, for example, we've been looking at some basic classifications that we could try and bring in. Now, whether we do that this year or not is another thing, but at least we're playing in that space. Likewise, on the ED side of things, with the ED work that's coming up, we're also doing a little bit of work ourselves, just to try and understand the effects on New South Wales that we can then, and the learnings from it that we can bring into the national exercise. You know, it's and I think it's critical that the national exercises continue.
Okay. Nick, you had your hand up before.
Yeah, I guess just two comments really. One, in terms of internal classifications, we've tended to do a lot of work around the outpatient, non-admitted space. I think we're one of the few states that does the neuter review split in Queensland, and that's certainly a key area for us to further develop over the coming years. We've got an issue with outpatient long waits, so anything that helps shine a light on that and I guess produce more useful information for us to have clinical decisions is a good thing. I think just probably in opposite to ACT really, we let contracts worth about 11.5 billion with the HHS, it's only 8 billion's covered by ABF. So we've spent a lot of time over the last, I guess, 12 months trying to really look at primary and community care and how you count, how you classify. I think we've just started with that one, but I think that's an area where if we're going to get into integrated care, we're going to start to move care out of the main acute hospitals. That's what we've got to understand more, and I don't think we do in Queensland at this moment. So I think new funding models around that is a key area of development.
Beress?
I think we haven't been doing any classification development internally within Western Australia. We've pretty much been using the time to get the classifications across the whole care spectrum really to round it out, because pretty much going back to when we moved into ABF this time round, which was in 2010-11, there were still the classifications around acute, and that was sort of working quite well, but rounding out and getting all the classifications across all the product types, irrespective of the utility of the individual classifications, has actually been very important in putting the structure in place and getting some clarity around how the system works. One of the fundamental things we did, which we needed to do, was implement a new admissions, readmissions, discharge transfer policy, commonly and known as the ARDT, because that's enabled us to get the system to be compliant with the various aspects of care and how they should be classified, because contrary to what Winston said, in some cases we were counting 120% of the activity in certain cases.
Janet's closing her ears at that one. Okay.
Yeah. So that's been an important part of that, because it also has enabled parts of the system to think around the way that services are delivered, etc. So it's engendered some of that. So it hasn't actually necessarily changed classification systems, but I think we would be active participants in the IPAS program for the development of mental health and emergency department, and non-admitted being the areas that we need to get improvements in classifications, which hopefully will also lead us to changes in the way that we undertake purchasing, with not just a pure ABF approach to that.
So, Beress, I think part of your point is sort of the chicken and egg question, what comes first, and you're saying ideally we get the service model first and then we work on the classification. Is that part of where your thinking is?
I think because you're obviously maturing the different approaches to both classification and service delivery models at the same time, I wouldn't see one necessarily leading the other. I think we've got to do them in parallel. We know that the classification systems around non-admitted and subacute and mental health need a fair bit of change and improvement, etc., to make them much more clinically appropriate than they currently are. And along with that will come a maturity from the system around ways to deliver services. Because at the moment we've got pretty much a sort of structured approach where you either do this or you do that, whereas the classifications don't necessarily lend themselves to a better way of delivering services and funding them more appropriately. So it's an iterative approach to that.
I mean, I think the question that comes to me hearing that is what you might expect the currency of a classification to be if we want the service model to continue to evolve. And a couple of you have talked about moving care into the community, changing boundaries. We've all had a lot of experience in the acute space, but it gets a lot harder once you move out of the acute admitted space. So that's a good observation. Janet, was there anything you wanted to offer in terms of gaps from your perspective or priority areas?
No, thanks, Sharon. No, not so much gaps, and more a personal view, but I've been particularly keen for the work to progress on non-admitted services because, just picking up your own point and something echoed by my colleagues, and possibly also reflecting on the 120% activity, I think non-admitted has been one of those areas where for decades, literally, we've looked at the data coming through and being reported by the Institute of Health and Welfare and said, really? Really? How could this be so? It was and probably to some extent continues to be all over the shop. We've never ever counted it convincingly. You know, our measures are so mature and there's so much work to do, but I think the potential yield is so rich as well on the strength of surely the future of some of our most innovative ideas lie in that non-acute space, in what we do outside the hospital walls and how we get, when we get closer to primary and community care and those things which happen, as I say, outside hospitals, that we really start to innovate and think very seriously about the next and better way of delivering care to the population. I think the more we know about that, the more we understand it, the more we have ways of capturing it, which assists in analysing not just cost but outcomes and quality and safety and appropriateness, the more expert our policy advice to government can be. So I think that's an area of very rich promise.
Okay. Francis?
I might make one more comment, which is the developmental work in classification and coding in subacute mental health, you know, the ones that we haven't been focusing on up to date. So the classification work in those areas, I think, will be useful not just in the context of pricing, and I'm not convinced we'll get to a pricing mechanism in the way that we perhaps hope in some of those areas, but that classification work will help us much more broadly in terms of service planning. And benchmarking and kind of understanding what's going on. So, and maybe even some productivity work that we might do within those sectors. So I think the work is an important platform and absolutely support the work happening. Not sure it will deliver us a refined pricing mechanism, but that doesn't mean we shouldn't do the work. And I actually think the use of it in those other areas will probably deliver us more benefits than in the pricing work. And probably the other comment, we also need to be careful about, whilst they're the big growth areas and that's where we want to put a lot of our effort, we also need to be careful we don't overinvest in making complicated financing mechanisms for very small amounts of money. And so that lesson came home recently when we were doing some work on palliative care in Victoria, and I might have this wrong, but I think we only spend 100 million on it. And it was sort of like how much you know, how complicated are we going to make this for this very small amount of money in the context of a $15 billion budget? So just also thinking about horses for courses and how we, how refined we get and how specialised we get in some of those funding models, I think we need to think carefully about. But certainly the classification work is very helpful in terms of service planning and modelling future demand.
Okay. We might move on to another area. So obviously, given the outcomes of the 2014 Commonwealth budget, what functions, or are there functions, I suppose I should be neutral about this, that you believe would be valuable if they were undertaken nationally? We won't necessarily say where that might be at this stage because we don't know. But given the experience of the last 3 or 4 years, what sort of things do you think would you like to continue to see being done nationally? From a jurisdiction, perhaps, from a state?
I'm being stared at here, so...
Yeah.
Look, I think it depends very much on the governance that comes in a couple of years' time. From our perspective, there are a couple of things that is critical that continue. I think that the pricing, the national efficient price setting needs to continue. I think national classification development and maturity needs to continue. I think the national standards that have been established for the costing, which underpins everything, should continue. But all of those need to continue if it's through IPA, is an independent IPA. And I think the independence is critical. Otherwise, I suppose the reliance and impartiality and confidence that independence is given may well wane. The other thing, though, is that because I think those functions are critical, whether they're done by IPA, if that's the way the governance goes, or by collective of the jurisdictions, or whether we do it ourselves is still up in the air. But from our perspective, I think the critical things to continue is those 3 items in particular, governed by an air of independence.
So you mentioned pricing. I was interested, do you mean pricing, or do you mean benchmarking of costs and the sort of portal, transparent information on costs across
both,
LAGs?
but I think pricing is still a necessary element of the system.
Okay.
Yeah.
Different. Winston?
Yeah, I just take your point, and it was one of the ones that I wanted to raise on this board today, that I think nationally, as well as the other bodies created by the NHRA, I think IPA has a strong role to ensure that we do use this data for benchmarking purposes. We have strong and robust data sets that can be used for those purposes. We need, well, especially us in ACT Health, we need that data to drive where the efficiencies are, where can we actually drive the changes across our health system. And I think IPA has that strong role into the future. You have those strong data sets. Can we please get that information out there? And I note what Kevin Willard pointed out this morning, that the views on the data need to be at the patient care delivery level. And I fully agree with that. We're smart enough at the jurisdiction level to actually then roll that patient level data up. But the thing is that I think we need to get that information out to our clinicians who are making those decisions at the patient level every day. We need to, well, for us here, realise that we do have a strong data set. Sure, there are minor changes that we can make here and there, and we can make, small minor changes to it. But we need to use it, and it needs to get out there. It needs to be part of the processes that information gets out and is disseminated as widely as humanly possible. ACT realises that we're delivering the most expensive healthcare in Australia. Let's just realise it, okay? And then let's start to use this data to make the changes that we do need to make.
Okay. Nick?
I guess
saw
just,
you,
yeah, I mean, just one comment to add, really. I think the benchmarking's the key thing, but it's got to be timely. And I don't know whether Diana or Dan are here, but we had lots of discussions on the nipper jack, which I also sit on, around the timeliness of that comparative cost data, and producing 11-12 data is an interesting concept in 2015. So I think how we get timely data, and I'm sure my team might kill me for this, but the amount of time it takes to do NHCDC and roll it forward and get that, we actually need some more real-time quarterly data that we can benchmark across the states. So that will be my key thing.
Okay.
And certainly from South Australia's point of view, I mean, we think IPA should continue in its entirety. I mean, it's the value that it's brought to a small state to be able to benchmark across the whole system has been quite powerful for us. We do need to continue to do that work, though. We need to keep our national hospital cost data collection up to date. The classification work needs to reflect changing clinical practice and patient demand. And we need to continue to understand the variations in cost based on service delivery models and clinician practice. So we think that work really should continue at a national level to enable us to do that benchmarking.
Okay.
It's the best way for us to drive our costs down and to understand variation in practice.
Any different views? Or a subset of important functions? I don't know, I'm just looking at Francis.
Maybe. So, you know, everyone votes for national classification coding, you know, so absolutely. So I agree with New South Wales. I do agree with another state at some point, which governance is one of the key issues here. And I think it's quite a tricky time for the IPA and for us all to think about how we structure this work nationally. So we've all got to, in the context, if we could just remind ourselves of that little bit of history, which we had the National Reform Agreement, the Commonwealth was going to contribute some additional money, and that additional money was going to be delivered through an activity-based funding system. We set up the IPA to get that going. Now we've not got the extra money, so the 16 billion's gone, and we've also taken, and also the Commonwealth has said no longer ABF mechanism to deliver the Commonwealth money to the states, so we're back to a kind of weighted population, some sort of way of doing it. We won't ask Janet to share because she probably doesn't know yet, but we haven't quite worked that out. So I think that's kind of interesting. So some people will be sad that we haven't got national activity-based funding as a mechanism to deliver funding from the Commonwealth to the states. So yes, that's true, and whether that's a good thing or a bad thing. If that's gone, then that changes the dynamic between the jurisdictions, between the Commonwealth and the states, really, about the nature of the IPA work. And so I think that's interesting, and I think that provides an opportunity to do some different things, and I think they can be positive. So if we all vote for continuing to work on national classification coding, costing, benchmarking, all that, then and that's a good thing. Then really, how does the IPA, in whatever form, governed by whoever, embedded in the Commonwealth or not, however we kind of do that, I think the interesting bit is what role can a group like that play in developing innovative funding models? And I do wonder if that function is delinked now. If activity-based funding is delinked from the Commonwealth contribution, does that give more freedom and more opportunity to be innovative and perhaps get more cooperation from the states in doing that? Because at the moment, for those of you that aren't involved, you don't have to kind of share in the agony of some of the jurisdictional advisory committees, because really, some of these decisions, they feel like they're remote from funding, the way the NEP works, the way NWAs are calculated, the weights, how the weights work. But they are all driving Commonwealth contribution to states. And that becomes very important for states in terms of protecting each of the states' budget position. And so I wonder if I hope that we've got enough maturity in the system around national collaboration and cooperation around classification, coding, counting, etc., that we can continue to do that, and then we can maybe move on to the innovative funding models that are not necessarily driving the Commonwealth contribution. Delinking those things might be helpful, and I'd be fascinated, and it would be great if nationally we can kind of come up with some sort of better understanding of pricing and funding models and incentives that are kind of off the shelf that, then states can pick up and go, oh, great, there's a fabulous way of funding palliative care, or there's a fabulous way of funding outpatients. and it's useful for the jurisdictions, but it's not necessarily driving the Commonwealth dollars. And I wonder if that's kind of an opportunity for us in the future.
So that sounds like you've taken off an economic rationalist hat, and I'm thinking back to sort of, you know, the origins of the case mix development program, and continuing on a little bit with classifications. How many healthcare agreements, Medicare agreements we had, states will work together on a classification of non-admitted services, and it went nowhere over 10 years. And so my heart tells me that unless we tie money to something, it's going to be much harder to get progress.
Yeah, so I agree with you on one level, but I think we've had 5 years of intensive activity where now most states are engaged in the concept of ABF funding and better, increased accountability with devolved governance, the whole deal. So I think that now that if most states are using a devolved governance arrangement, meaning boards and separation of departments and service providers, if that's embedded in each of the states, then to make that system work, you actually have to have proper pricing, funding, and funding models with the right incentives. And so we've embedded the boards and devolved governance, and we've had 5 years of intensive activity driven by needing to make sure we watch what the Commonwealth does with the money. And we've got some systems in place, and I think now that we've got that devolved governance arrangement, then states absolutely need those funding mechanisms, because you cannot be a system leader and have formal accountability arrangements without being able to have a currency to talk about the activity and the outcomes. And so I actually think that the states now, because most of the states are in that position, have an absolute driver to make this, to ensure that work happens. So I think we're, I'm being kind of positive today. Well, I think we're in a better place than we were 5 years ago, because the states need it. It has to be in your toolkit if you, as a jurisdiction, have formal accountability arrangements with services to drive the kinds of outcomes, orientation, and efficiency that we need.
Okay. So states are going to be looking to either purchase or jointly sponsor some of this work on an ongoing basis. Dissent? Interest?
Depends on the structure.
Depends on the structure.
Depends on the governance.
Okay. No one else?
I think we have to make a contribution, clearly. But I agree with that it's about leadership, commitment and accountability, and that context is different now than it was 5 years ago.
All right.
I mean, we've got a model for governance where the states contribute in the National Quality and Safety Commission. I always forget the right way round to say the title, but Deb Picconi's crowd. The governance of that seems to work pretty well, and that because the states are actually at the table in terms of investing in it, and I think that's got quite a good collaboration model. Now, who knows where the IPA's going in terms of independent, embedded in the Commonwealth Department, or more governance that has jurisdictions around the table there. So I'm not sure where it's, nobody knows where it's heading, but I do think that the Quality Commission gives us a model for how states can come together in a governance sense and have nationally sponsored work, and I think that's worth thinking about in terms of the next round of whatever version the IPA evolves into.
But what opportunity do we have, though, to actually influence, Francis, what happens to IPA? I mean, it's surely that the states have an ability to inform what actually happens in the end, because we are the beneficiaries primarily.
I think that's called Health Ministers and COAG Health Council, and all those, the retreat coming up soon, the Camp Tony, Camp David, whatever, I won't get, don't tell on me, Janet.
These two were colluding beforehand. I'm not sure what sequence.
So I think, way above our pay grade in terms of influencing that. But, I'm sure Janet and also the IPA and the IPA board, but I think these are COAG Health Council kind of conversations that need to be had.
Okay. Janet?
Sounds like about time for a Commonwealth message.
Yeah. It usually follows a Victorian one.
Not just here for gender balance. Okay, where to start? Francis has said a number of times, you know, we don't know what's happening to IPA. It is the case that the government hasn't yet made final decisions on the way it's going to implement the decision announced in the 14-15 budget about potential agency mergers. I know it's been a long time, believe me, I know it's been a long time, but it is working its way through that. It's part of a larger series of or constellation of decisions around small government, and it's fairly densely choreographed. So I'm hopeful that we should see a decision from the government on that fairly shortly. It is the case, and it's certainly been referenced and is widely discussed, that the funding arrangements for the provision of Commonwealth funding to public hospitals will change in 17-18, and that's now you know, in the budget papers and repeated this year as revealed last year. So we're moving to a different funding arrangement with the movement to the new indexation with population growth and CPI. But that in fact should not be misunderstood as a comment from the Commonwealth Government on the value or benefits of ABF. And I think that is a mistake that is often made. Indeed, I think there has been language used from time to time, even from the Commonwealth, which conveys that impression. It is not strictly accurate, and in fact, I don't even think it's broadly accurate. There is, within the Commonwealth, and certainly in the current Health Minister's mind, a fairly clear understanding of what appear to be the emerging benefits of moving to an activity-based funding system. Now, some of those might be benefits which would have accrued anyway with maturation of a system of funding, ABF or anything else, but as people become more familiar with it and as budgets tighten generally, chances are we might have achieved some of the turning of the curve which we've seen in the last two years, but maybe not quite that significant. So I think there can be some attribution to new ways of doing business, new ways of classifying, counting, coding, reporting. So the Commonwealth looks at, and when I say the Commonwealth, I'm obviously talking about the government, but hopefully with some advice from bureaucrats, is looking at all of this as it's happening and thinking, what are the sorts of incentives or levers or platforms which are available to governments, plural, 9 governments, which might be able to sustain not only a dialogue and a conversation about how to get better at funding the system we want to deliver, but talking about models of funding which then convert into models of service delivery, which turn into outcomes for patients and so on. What is the nature of that ongoing conversation? What are the settings in the system, notwithstanding and in full light of the decision which has been made about what's going to happen in 17-18? Now, I know that requires some gear shifts in your brain, and it's not sequenced in a nicely stepped out, logical, programmatic way. But I am being straight with you when I say that you should not read the 17-18 decision as being the same as they're turning off ABF, because that's not the intention. There is, particularly in this minister's mind, a view that there should be available to us all a means of continuing on with some of the very useful work which we've been observing over the course of today and will again tomorrow. So this conversation that we're having here is really on point. It's vital that we think about this strategically. And picking up Jenny's point, well, what's the nature of the voice that can be exercised by states and territories? Francis is right. We already have the structures which allow those sort of conversations to be held, and indeed they are already happening. Not only is there RMAC and the COAG Health Council, but there's been recently initiated a meeting of deputy secretaries convened by Mark Cormack from my department and had an early discussion about this. Undoubtedly it will continue in that forum. We need a decision about the future of the pricing authority. We need those conversations to continue. We need these sorts of fora to continue to have and be bold enough to have the imaginative conversations about what can we do, how can we do it, what is the resourcing required to achieve it, what are the incentives we put into place, so that we're all pulling in the same direction. And the Commonwealth is absolutely prepared to play its part. And I think it's an important realisation that It's not about switching off the national infrastructure, the national classification, the costing and reporting standards, the data collection systems in HCDC. For all its warts, it's the best we have and it's getting better. We need to find ways of continuing all of that with so much sunk cost, We started this journey, those who were around, of course I was in kindergarten, but in the 1980s, 30 years ago. I mean, it's astonishing to think that much time has passed. The first ANDRG was issued in 1992. And think of how much ground we've covered since then. It's too important to throw away. I absolutely agree with the comments which have been made specifically by Francis that we shouldn't be captured by it because it's not the be-all and end-all. We need to keep thinking broadly, laterally, and not with tunnel vision that ABF is the only way or the best way. But we need to hold on to what we've achieved and move on from that. And I think, I mean, if Francis talks about being positive today, that's my natural bent. And I actually think there is a lot that is available to us over coming years, particularly the next two when there is still a job for the IPA to do in the national efficient price. But moving beyond that, let's think creatively and see what we can manage.
Okay. So Janet's just given me the perfect lead into my last double-barrelled question and reminders to everyone, put questions in via the app or get ready to go to a mic once we've had our last set of double-barrelled questions here. So the question, following very closely from what Janet has just indicated, put aside for one moment the obvious uncertainty about governance, the fact that the funding is no longer there in the same shape and form as it was prior to the 2014-15 budget. Can I ask the states to reflect on the two elements that Janet just mentioned? What form do they think they'll use ABF after 2017? Is it, you know, no one's going to drop their bundle and throw it out the door, or I'm looking to see. And beyond that, we've already had a couple of references to other models of care, whether I think you were referring to care point or capitated models. Nick's, I think, talked about crossing the boundary between hospital and community care. So let's put aside the governance uncertainty and get a sense of where each jurisdiction might be going, both with ABF and beyond ABF.
Do you want me to start?
Yep, Nick.
I'm trying to keep away from sort of funding arguments between Commonwealth and states because that's the sort of topical issue in Queensland at the moment. I think
you do notice that this was an unusual panel because normally we have the Commonwealth at one end and everyone's organised by state, and Janet very kindly said, I'm going to sit in the middle.
So I guess, I mean, when I was sat at this same panel last year, I said that Queensland was going to look around a population-based funding model, and we're probably 5 months into a formal evaluation about introducing population-based funding into Queensland. I think it's less clear at this time than it was 5 months ago whether we'll do that or not. We've gone into the great detail around population-based funding, and a number of factors really in Queensland would restrict the use of population-based funding. The geography, the Indigenous status, we are very different in terms of 16 HHSs, so trying to bring in one standard population-based funding model, I think will have aspects of that to try and drive allocative efficiency across Queensland, but I don't think we'll go a full-blown population-based funding model. I think we've probably got a great opportunity in Queensland with the primary healthcare networks. I think, and Janet may correct me, we're the only state that's had 3 of its HHS groupings actually come to form 3 PHNs. And I think with a lot of the things that we've talked about around Commonwealth, state, and hearing Keith this morning, how we bring budgets together and actually try and cross that secondary primary care divide into a more pooled budget arrangement, I think is something we'd really want to try and explore in Queensland. We've had some very encouraging conversations with the Commonwealth over the last 12 months around PBS, MBS, and really trying to bring all that data together, particularly around the integrated care. And I think one of the areas we'll look at is year of care funding, whether we can introduce that on a pilot basis, and we're certainly looking at that within 2 HHS at the moment. So I think ABF will always stay there, I think, in terms of pure hospital funding. I think our HHSs will always use that. I think we'll use that for any inter-HHS flows in terms of charging, but I do think we will have elements of population-based funding and also elements of year of care funding around some of those chronic disease management cases.
Okay. And sorry, can I just clarify, the population-based funding, you're talking about essentially using that as a first tier to do some minor redistribution across your 16 HHSs?
I guess we're looking at one level, the whole 11.5 billion being done on a population-based funding. The more we've drilled down into that, I think we've started to really narrow the scope of it, but we still could potentially, and this hasn't been decided on yet, see the vast majority of that money operated on a population basis. That's quite different to what we've got now, because even on ABF at the moment, we fund on place of treatment. We don't fund on place of residence, but as we've gone down a more autonomous route for our HHSs, actually giving them the budget for their residents and allowing them to have some control in terms of what they invest in, where they get the services from. I think we've certainly reaped the benefits of that more autonomous HHSs over the last 2 to 3 years, and we wouldn't want to see that diminish going forward.
Anybody else on these? Neville?
Where to start? Look, we started in New South Wales, I guess we effectively said this is a greenfields site for us, and took a boots and all approach to jumping into the ABF sphere. It didn't take us long, maybe 18 months, before we realised that ABF wasn't the game changer here. ABM was the game changer for New South Wales, and we've progressed along that path very heavily. So that's the funding to the management. The ABF is just an element that supports the ABM approach. Once we move to looking at activity-based management, the pickup across the system grew exponentially, particularly in regards to the clinicians and the people looking at all the service provision. So from that perspective, from our view, it's had a huge impact. Both our Minister and our Secretary have clearly stated that the way that the approach that we've taken over the last couple of years is the correct approach for New South Wales and will continue into the future. So we're working along on that path. Notwithstanding, we've had so many clinicians come up to us and say, look, with the information that you're providing, the knowledge, the insight that we're getting from the data that's there, please don't change it. Please don't throw it out, particularly after last year's budget, federal budget came out. So we're, from all intents and purposes, we're rolling along. Having said that, we think we've got a pretty good model, and it stood the test of time over the last 3 years. We're just about to do our 4th one. And it's an activity-based funded basis, and we try to follow the national model, unless there's a very good reason for departure. But in our model, there are 2 elements. One's the pricing mechanism, the other is the purchasing mechanism. And the purchasing mechanism shouldn't be understated as to how it can be used to drive change in some of the elements that Francis has mentioned and others have mentioned here about elements of the funding mechanism that need to be captured. So, in terms of population funding and where people are crossing over between LHDs and so forth, our purchasing mechanism takes a lot of that into account, and then the funding follows suit. So from our perspective, and we're finding that as people are raising these challenges and these little intricacies, the model seems to be stacking up. We have to do tweaks here and there, but we're quite prepared to do that. So from our perspective, and I think the other thing is that what we're seeing is that there is great scrutiny happening around how services are being delivered, patient journeys, frequent patient visitations, how best to provide services to keep people out of hospitals and so forth. We're finding that there is more and more engagement of that happening simply because the transparency that's there and the data that's going out there is available. I guess the testament to that's the enthusiasm of the people here from New South Wales. In particular, I notice in their presentations, you know, we think that the way we're going is definitely going to provide better outcomes for patients, and that's what the whole thing's all about anyway.
Okay, does anyone want to have a go at crossing boundaries of care, chronic disease? I know, Nick, you mentioned it. Beress, you've got...
I'd first like to just thank Janet for reminding me I wasn't in kindergarten in 1980. I was doing something around case mix. Thanks for that. I'll just go back and just follow on from Neville's discussions. I mean, from a Western Australian government point of view, WA Health is going through a fairly significant reform program, and one of the projects within the reform program is embedding ABM into the health services. So it's a fundamental part of government policy at this stage for us to proceed down that path. Whilst we can deal with different funding mechanisms going forward, you still need all of the infrastructure in their classifications systems, as we discussed previously, to support that approach. But it's pretty much following on from some of the discussions that were held this morning and some of the presentations around getting the clinical engagement at that point of view, at that point, to actually support the way the system actually reacts and becomes more efficient, but delivers better quality care for patients as part of that process. So fundamentally, the decision from the Commonwealth Government around funding in 2017-18 makes no difference to the journey we're on in regards to ABF and ABM as our fundamental plank. And as part of that, I think I referred to it before, was that as we continue to mature those processes, looking at models of care, crossing boundaries of current care delineation, etc., will be a part of that process, which we'll be able to follow through. And I think that, as Francis said before, that if there is the ability to develop a set of models nationally which people can look at, would actually be and adapt them and implement them as fits for your services, would actually be a good way to go.
Okay. Winston, you were...
This is a very simple one from ACT Health, you know, asking about what opportunities will we take to move beyond ABF. How about this? We deliver healthcare at a further efficient price. We are doing so, and I've got to congratulate New South Wales for the zealotry that they've taken on with ABM. And as I said, I've gained most from New South Wales presentations at this conference around exactly what you are doing with implementing ABM. So we're going to, I'm going to go back like a zealot and go back and talk with ACT about implementing further activity-based management changes. Just to give an update, we're looking at other models of community-based services. You know, we have a lot of those services which are hospital-based at the present time. We have a lot of them based at the hospital. We are looking at that at the present time and seeing if we can actually bring about further efficient services. Of interest, we are looking at contract care, both internally funded, internally provided and externally provided. So we are looking at, as Victoria's done with some of its primary care services and the levels of NGOs which provide some of the services, we're looking at exactly that at the present time, coming up with flexible ways of healthcare delivery that can be done in an efficient fashion. Yeah, so kudos to New South Wales. We will be taking that further. I'm looking forward to coming to this conference in a couple of years' time and showing how we've pushed that on.
So I just need to understand, because a couple of people have talked about activity-based management, but still talking about flexible funding models extending into primary and community care. I'm not assuming that you're saying that ABF is the way forward for all of those new models of care? Yes, no?
I was struck by Kevin Willett this morning talking about fixed and variable cost.
And particularly the slide with urgent, emergency, all of the different payment mechanisms, and then...
Yeah, very much taken by that, but I will heed a slight bit of caution in that, as I said, we've looked at that and do note the work that it does take to really break down those fixed and variable costs.
So I think the interesting conversation in the next few years, I'm hoping for an interesting conversation about how primary care is funded. So I think we've spent 5 years poring over hospital funding and IPA, Independent Hospital Pricing Authority. Can't wait to see what would it be, the Independent Primary Care Funding Authority. The reform of MBS, so Steve Hambleton's chairing a group, I think. So I'm looking forward to what that's going to offer, because I think that's also the other part of the equation. And I'm also interested in any changes that private health insurance funding arrangements might make. So I think there's so of course we've got lots of work to do in our own backyard, and we will continue to do ABF. We will refine acute ABF. We will look at some capitation funding for frequent hospital users. We'll probably move to a fixed and variable cost base for our emergency department funding, and we're living in hope of something out of the IPA for subacute and outpatients. And so we'll kind of do all of that work, and that will be good. But to me, the next big conversation is really, if we're chasing the holy grail of integrated care, then I'm really interested in where the reform of MBS, both in the context of primary care, but also in the context of specialist care, so community-based specialists, and consultant care in the community. Those two, combined with private health insurance, I think we sort of need something to plug into in terms of the hospital or the health service work. And so at the moment, what we've got is fee for service in those worlds, really hard for us to connect with. The best people come up with is pooling funds. And look, maybe that's where we'll get to, but I'll be very interested to see if we can put as much effort as we have into the hospital funding arrangements and to put that into the primary care world.
Okay. Jenny, I think I've missed you on this one, have I? Or
I'm happy just to add that South Australia will continue with the activity-based funding, but recognise the previous comments about the link between pricing and commissioning or purchasing and models of service delivery. So I think the move to activity-based management is very important, and it will be the way in which we'll be able to control costs into the future.
Okay. All right, I'm going to open it up to questions. Have we got any on the iPad yet? And also from the mic for people who want to volunteer. Just have a look. Okay, so it's a bit hard to see. I've got somebody out there, yes?
Thank you. That's a wonderful set of presentations. I really enjoyed the day. I'm a doctor. I work in South Australia. One observation I'd like to make is that you're talking about classifications and precision, and I think in the acute care sector that's largely due to disturbance of bodily functions and structures, and you can get really good and accurate about that. But as you move away from the acute care sector, the other dimensions of personal and environmental factors start to dominate in terms of why people seek care. They might be harder to measure, and it might be one of the limitations in terms of how you distinguish between acute and other sectors.
Comment or a question, anyone? No?
It's down to the notion of what is illness, and whether illness is something we measure or is it participation.
So I think that some of the commentary has been agreeing with you. It's easy to count and classify if you're sitting in your pyjamas in a hospital, having things done to you. When you start funding in the community setting, it's trickier. But I think what your comment goes to is even harder, which is early intervention and the kind of multiple influences on what actually drives people to seek care, or in fact what influences their ill health. And I think in the prevention space, in the true prevention space, we're nowhere on funding models.
So on a clinical basis, if you looked at the return to work of someone who'd had myocardial infarction, the best predictor for that was their expectation when they presented to hospital. So you ask them, are you going to go back to work? That would be the best prediction. Wasn't their infarct size, wasn't their sort of cardiac mobility or anything else. If you look at the functional status and outcomes of people with rheumatoid arthritis, the best predictor is actually your level of educational attainment. It's not your disease activity, it's not your level of deformity, it's not those sorts of things. So these are personal and environmental factors which determine health. When you're having a cholecystectomy, a knee replacement, coming in with major trauma, having a myocardial infarction, you can classify those things quite well. You can determine what inputs you need to do to get an output in an acute care sector. What I'm suggesting is that's fine, but as you move away from the acute care, it becomes much messier.
I agree.
So how we carry forward those outcomes. So I'm looking at the questions. Some of the questions that have come through, we've heard some responses from, so they're a bit similar. But this question is, should ABF or other activity models be expanded to primary care? And we did start talking about primary care. And I guess first we have to decide what is primary care. Is it just general practice? Is it the state-funded community health services, etc.? And so do people think ABF would be the way to go forward with primary care? And if so, would that help address issues of cost shifting, is the question.
The first answer is it already is. Fee-for-service is actually a form of activity-based funding. So our dominant funding mechanism or model for primary care, that is care provided by general practitioners, is fee-for-service. Therefore, we're already there. What you might think of fee-for-service and the incentives and disincentives embedded within it is actually separate from the question of how you would define that payment model. If you were to broaden the definition of primary care and to encompass things other than those services subsidised through a payment through the Medicare system, I think you get into a very different space. I think the prior question that we have to answer is, what are we seeking when we ask that question? What is the goal? Is there an assumption in the middle of that movement to an activity funding platform would deliver better care, cheaper care, better outcomes? I think we have to drill down and ask the prior question before we want to venture to an answer to that particular question. I could see equal arguments for a blended funding model which was part infrastructure so that you have a fixed level of funding for opening your doors in the morning, and then some variable component which had to do with the diagnoses of the people who were coming in and seeking your administrations. So I think we have to understand why before we ask whether.
Okay. Have we got a second one? Oh, thank you. From the floor. Thank you.
That's a question for Nick Steele. The teaching and training research costing study kicked off data accumulation this month. There's 3 sites in South Australia, the other 15 from Queensland. All the other territories and states haven't participated. Queensland's investing a lot. What do you expect to get out of the TTR costing study?
You're helping out as well, are you? That's very good.
Apart from ulcers.
I think the TTR was a joint decision between the HHSs and the department within Queensland. We actually had IPA and their consultants come along and actually have a discussion with all the HHSs. We got a massive response from the hospitals across Queensland. They wanted to take part in this. This was a key issue for our clinical centre, and it's certainly an area where we want to understand more the costs associated with TTR and also how we're actually going to build that into future funding models. So I think the depth of the analysis and the depth of the data is going to stand us in good stead for a future funding model.
Do you anticipate significant movements of funding from Hospital A to Hospital B?
I'm not sure I want to comment on that, Bernie, at this point. I think we'll wait and see what the analysis shows. But thank you.
Okay, we've got some more questions in the back there, is that correct? Or people just trying to get out early? I can't see from here. Yes, no? So some other questions, and we have discussed a few of these. Do you consider that setting the price is important beyond 2017? And I think, Neville, you've already said yes.
So I would think about it as a national reference price,
yes,
rather than necessarily, it's not a real price, and it's really only a benchmark price, which is basically a sum of the costs. So I think we have to rethink what that price means. It's different from the NEP.
Okay. No different there. Okay.
Sharon.
Yes?
Happy to ask a question if it helps.
Okay.
You can't see me, I'm way back here.
No,
Joe
I can't,
Scuteri.
sorry.
Yeah. Hi, look, I think a comment and a question. One of the great benefits that if in fact we do move away from the Commonwealth's share of hospital funding being on an ABF basis, one of the great benefits that will be left behind is I think a quantum improvement or a quantum jump in the quality of hospital data that we have available to us in Australia. You know, we've definitely gone up a ladder as a result of, I think, the implementation across all the states and territories with the Commonwealth of ABF. My question then is, which I ask regularly at conferences, particularly when the subject of integrated care comes up, you know, can we actually have integrated care without integrated data? And I think we'd go a long way towards understanding the opportunities that integrated care might create if we just simply aggregated 5 or 6 data sets and allowed them to be linked, including MBS, PBS, the aged care system, public and private hospital data and public community health services data. If we managed to put all that together and link it, we would go a long way towards understanding the opportunities that integrated care might actually provide for us. And I wonder what the panel think.
I see a lot of nodding of heads.
I disagree.
Vote with 2 hands. I sometimes wonder whether the patients will get there before us and Dr. Google will actually kind of get the data in one spot before we all get the data in one spot. But I did hear a rumour recently that Victoria actually got its hands on some MBS data, so I live in hope.
I think the integration of data is certainly key, and all the comments I've heard from the Commonwealth, they're quite happy to share MBS and PBS data. We've started to try and link that with some of our pilot sites in Queensland. The interesting thing for us, we had our new health minister at a roundtable probably a month or 2 ago now, and it came as a surprise to him we don't have a unique identifier in Queensland. So actually the same person can have 3 or 4 different numbers depending on which hospital they're in. So I think we've got business to sort out locally in Queensland first as well.
Okay. All right. If there are no other questions, I think I might draw it to a close and thank the panel on your behalf, everyone, and thank you for your questions.